For this video, we're going to discuss kidney disease. Let's define first what is kidney disease. Kidney disease results when the kidneys cannot remove the body's metabolic waste or perform their regulatory functions. This lecture focuses on the two types of kidney disease, which are the acute and chronic kidney injury. This video lecture covers the renal replacement therapies such as the hemodialysis, continuous renal replacement therapy, and the peritoneal dialysis. We'll also be discussing about kidney transplantation. So, acute kidney injury. The content of this presentation includes the definition, categories, its phases, and of course the diagnostics. So let's define first what is acute kidney injury. So, it is a sudden decrease of renal function wherein the kidneys aren't able to filter blood like it should. So, there's a buildup of waste in the blood such as the BUN, creatinine, which are waste product of muscle breakdown and protein breakdown. There is also a buildup of fluid and electrolyte imbalance. So, this disease can be reversible if it is caught early and the cause is treated appropriately. This disease also called acute renal failure. So there are three categories of acute kidney injury, which are the pre-renal, intrarenal, and post-renal failure. So for the first category, which is the pre-renal failure, as the word itself, pre meaning before the kidney. So this happens when there is an issue with perfusion. So as we all know that the heart and the kidneys go hand in hand together. So basically, the heart takes the blood and oxygenates it through the lungs and goes back to the heart and it pumps it out through the body. The oxygenated blood goes through the descending aorta and go into the kidney through the renal artery until the nephrons of the kidney. So the nephrons are responsible for filtering the blood, reabsorbing the nutrients, and creating urine filtrates which is voided out to the body through the urethra. However, if you get perfusion issue, there will be a decrease in the function of the kidney. So there's a decreased amount of blood that is going to the kidney to filter and the kidney is being deprived of nutrients. So it's not able to work like it should. So eventually it can lead to intrarenal injury. So what are the causes of pre-renal failure? So the first one is cardiac issue. So this happens when there is a damage to the heart muscle or is not being able to contract properly. So as a result, there is a decreased cardiac output. So an example of which is a myocardial infarction. So another cause is bleeding that may be internal or external. And another one is dehydration, such as excessive diarrhea or vomiting, which can lead to hypovolemia. And another cause is that burns. So for the second category, which is the intrarenal failure. So this happens when the nephrons are being damaged or the kidney itself. So if you have problems with your nephrons, there is a decreased ability to filter blood. So it cannot remove waste and it can remove the excessive water and it's gonna be able to maintain the electrolyte levels. So the causes of intrarenal failure includes infection such as the untreated glomerulonephritis and then the recurrent pyelonephritis. Another cause is that the acute tubular necrosis, ATN, which is the damage to the filtering tubules or bodies of the kidneys. So what are the causes of ATN? So for the first one, burns and crushing injuries that may be due to the breakdown of muscle cells and the subsequent release of myoglobin that can clog the tubules of the kidneys. Another one is the severe blood transfusion reactions. So this happens when the hemolysis of RBC causes the release of massive amounts of hemoglobin that can obstruct the tubules. So another one is the nephrotoxic drugs such as the aminoglycosides and NSAIDs. So another cause of intrarenal failure includes the contrast dyes. So for the third category, which is the post-renal failure. From the word itself, post meaning after the kidney. So this happens when there is a blockage in the urinary tract. Moving on, there are four phases of acute kidney injury. The first phase is the initiation. So it starts from the cause to kidney, either pre-renal, intrarenal, or post-renal failure and ends with the signs and symptoms. It is important to find the cause to correct and prevent long-term damage to nephrons because if not corrected, it will lead to chronic kidney injury or the end-stage kidney disease. For the phase 2, which is the oliguric phase, this is where you will notice that the patient having the urine output less than 100 ml per day. Why? Because the glomerulus has decreased its ability to filter blood. For the clinical manifestation includes the increased BUN and creatinine, so you will notice that there is a change in urine status of the patient and itching is manifested. For the nursing intervention of this is low protein diet and safety. For the second manifestation is hyperkalemia. So this is decreased excretion of potassium and a life-threatening. So watch out for cardiac issues, those who are high in potassium and tall peak T waves, wide QRX complexes, and prolonged PR interval may represent hyperkalemia. For the nursing intervention, restrict potassium foods, monitor ECG, the labs, and administer K-exhalate either per orem or rectal to lower potassium level. And another one is the increased fluid in the body such as edema. So there is a risk for pulmonary and cardiac issues and hypertension. Nursing intervention is limit fluid intake, strict INOs, daily weights, monitor BP, the lung sounds, and autosat, and look for swelling. And another signs and symptoms, metabolic acidosis. So the patient may be confused and having cosmal breathing. So this is the deep and rapid breathing to blow off carbon dioxide. So this is a compensatory mechanism to increase the pH. So for the nursing intervention, monitor for safety and the respiratory status. Another clinical manifestations of oliguric phase is mild hyponatremia, so which is the low salt level because the blood is diluted from the extra fluid that's in the blood. So the treatment of this is dialysis. So some patients skip this stage and enter the next stage, which is diuresis. So the diuresis, which is the phase 3, so this is where the nephrons are on their way to recovery. So they have the ability to filter blood but can concentrate urine. So the GFR starts improving but still abnormal and the patient voiding a massive amount of urine for about 3 to 6 liters per day due to osmotic diuresis. So watch out for hypovolemia with risk of dehydration, hypotension, hypokalemia, urine-specific gravity less than normal, and for the nursing intervention includes strict INOs, daily weights, signs and symptoms of dehydration, supplements to replace the electrolytes that are lost because they are being voided. So moving on to the phase 4, which is the recovery. So it starts when the GFR returns to normal. So everything will be maintained in the recovery phase such as the BUN, creatinine, and electrolytes. So this stage can take a year or more depending on amount of damage and the patient's age. So some patients never make it to recovery stage because of too much damage and it may lead to chronic kidney injury or the end-stage kidney disease. For the diagnostics, the first one is the renal function test. So it is used to evaluate the severity of kidney disease and to assess the status of the patient's kidney function. Common tests of renal function include renal concentration test, creatinine clearance, serum creatinine in blood, urea nitrogen. So this is the end product of protein metabolism. The 24-hour creatinine clearance is used to detect and evaluate the progression of kidney disease. So for serum electrolytes, ABGs, CBC, ultrasonography. So ultrasonography is a non-invasive procedure that uses sound waves passed into the body through a transducer to detect abnormalities of internal tissues and organs. And the last is ECG.
Another topic that we will discuss to you is about the chronic renal failure or the end-stage renal disease. First of all, Rochelle will define chronic renal failure first.
So chronic renal failure, it is the progressive, irreversible deterioration of renal function in which the body's ability to maintain metabolic and fluid and electrolyte balance fails, resulting in azotemia or uremia. So azotemia is a condition that occurs when your kidneys have been damaged by disease or an injury. And you get it when your kidneys are no longer able to get rid of enough nitrogen waste. So for the uremia, it is a buildup of toxins in your blood, and it occurs when the kidneys stop filtering toxins out through your urine. So the GFR, or the glomerular filtration rate, is less than 20% of normal. Chronic kidney disease may result from any cause of renal dysfunction of sufficient magnitude. So the most common causes are DM, or diabetes mellitus. So it is a leading cause of chronic kidney failure. Chronic kidney failure is related to both type 1 and type 2 diabetes. Next is the HTN, or the hypertension. Because elevated blood pressure can damage the glomeruli and ultimately cause the nephrons containing damaged glomeruli to lose their ability to filter waste from the blood. Next is the chronic glomerulonephritis. The damage caused by glomerulonephritis reduces the ability of the kidneys to filter blood properly. Waste collects in the bloodstream and the kidneys might eventually fail. So the condition also causes a lack of protein in the blood because it gets expelled from the body in urine instead of entering the bloodstream. Next is the pyelonephritis. A continuing problem with a kidney infection is called chronic pyelonephritis. So having a severe kidney infection or repeated kidney infections can damage the kidneys, and it can lead to chronic kidney disease. Next is the obstruction of the urinary tract. So an enlarged prostate, kidney stones, or tumors. So they are the condition that results when urine backs up into the kidneys from the bladder, and it can block the urine flow, increasing the pressure in the kidneys and reducing their function. So next is hereditary lesions. So polycystic kidney disease, and then vascular disorders and infection. So lastly, medications are toxic agents. So toxins, in ongoing pressure exposure to fuels and solvents such as lead, soldering materials, jewelry, and even alcohol distilled in old car can lead to chronic kidney failure.
The pathophysiology. First, the risk factors such as diabetes, high blood pressure, family history, age over 60 years old, race or ethnicity, African American, Hispanics, Native American, and Asian American. Risk factors will start to the injury of the kidneys, then prolonged injurious condition. Nephrons will decline, which will result to massive GFR reduction, and then there will be accumulation of nitrogenous byproducts from protein metabolism and increased nitrogenous waste in the blood, or diuremia or azotemia, the increase of bone and serum creatinine levels. Then on the signs and symptoms will appear. Signs and symptoms will be discussed on the following slides. Next is the stages of CKD or ESRD based on GFR. Stage 1, greater than 90, kidney damage with normal or increased GFR. Stage 2, 60 to 90, remarks, mild decrease in GFR. Stage 3, 30 to 59, moderate decrease in GFR. Stage 4, 15 to 19, severe decrease in GFR. And stage 5, which is the end stage, less than 15. And the remarks for this is kidney failure. The normal GFR is 125. Next, let us proceed to the clinical manifestations of ESRD per system. The first body system is the cardiovascular system. Clinical manifestations are hypovolemia, hypertension, tachycardia, arrhythmias, CHF, and pericarditis. The cause of manifestations are increased fluid volume, buildup of metabolic wastes, chronic hypertension, and changes in RAAS. Then hematologic, anemia, leukocytosis, thrombocytopenia, and decreased platelet function. The cause of manifestations are decreased production of erythropoietin and RBCs, decreased survival of RBCs, and decreased platelet activity. GI system. Clinical manifestations, anorexia, nausea, vomiting, abdominal distension, diarrhea or constipation, GI bleeding, and uremic fetor or the urine-like breath. The cause of manifestations are buildup of uremic toxins, electrolyte imbalances, changes in platelet activity, conversion of urea to ammonia by saliva. Neuro. Clinical manifestations are lethargy, confusion, convulsions, stupor, coma, sleep disturbances, behavioral disturbances, and muscle irritability. The cause of manifestations are uremic toxins, electrolyte imbalances, cerebral swelling due to fluid shifts. Dermatologic. The clinical manifestations are pallor, pigmentation, pruritus, ecchymosis, excoriation, and uremic frost. Cause of manifestations are anemia, decreased sweat activity, dry skin, phosphate deposits in the skin. Then in the urinary system, oliguria to anuria, increased specific gravity, proteinuria, cast of cells in the urine. The cause of manifestation is the damage of the nephrons. Then a skeletal system, osteoporosis, renal rickets, joint pains. Cause of manifestations are decreased absorption of calcium and decreased excretion of phosphate.
So for the diagnostics, first we have here serum creatinine and BUN. So BUN is blood urea nitrogen test. So these tests are the primary tests used to check how well the kidneys are able to filter waste products from your blood. Next is routine urinalysis. So it is a common method of analyzing urine that is used to assess your health and to help diagnose renal and systemic, inflammatory, and neoplastic diseases as well as urinary tract infections and urinary tract neoplasms. Next is we have here 24-hour creatinine clearance. So this test is used to confirm the level of kidney function reported with the eGFR level or the estimated glomerular filtration rate. Also, we have here the serum electrolytes and then the ABGs or the arterial blood gas analysis. So it measures the balance of oxygen and carbon dioxide in your blood to see how well your lungs are working. It also measures the acid-base balance in the blood. And the kidneys and lungs keep this acid-base balance. Next is the CBC. So if you have low CBC level, it indicates that your kidney function is reduced. So lastly, we have here the UTZ or the ultrasound. So this imaging exam uses high frequency sound waves to view the kidneys in real time and is often the first test obtained to examine the kidneys. So it is significant renal parenchymal changes. So for the complications, first we have here hyperkalemia, which may lead to life-threatening cardiac arrhythmias if not corrected. Next is the pericarditis, pericardial effusion, and cardiac tamponade. Next is hypertension. And we also have here neurologic effects or the cerebral edema due to hypernatremia. And then we also have here anemia, and then lastly bone diseases.
The following are the management for ESRD. The drug therapies are calcium and vitamin D supplements, phosphate binders, antihypertensive and cardiac agents such as diuretics like furosemide and butanimide, digoxin, clonidine, ACE inhibitors like captopril and enalapril, alkalinizers such as sodium bicarbonate, essential amino acid supplementations like keto analog, erythropoietin, iron and folic acid supplements, cholesterol sulfonate for hyperkalemia, and anxiolytics like diazepam for neurosymptoms like seizures. And for nutritional therapy, first is low protein diet and oral fluid intake, then low sodium, low potassium, and low phosphate diet.
Nursing interventions, we have to monitor weight, vital signs, and urinary output. And we need to ensure dietary and fluid restrictions. We also have to watch out for signs and symptoms of uremia and teach strategies in avoiding thirst while on fluid restrictions. We have to watch out for symptoms of hyperkalemia. We need to teach methods to combat nausea. And also, we have to teach to avoid medications or supplements that might have an adverse effects on the kidneys. And lastly, referral to community support and mental health counseling.
So moving on, we will now discuss for the hemodialysis as one of the modalities of renal replacement therapy. So, a renal replacement therapy are treatment modalities that take over or replace the function of the damaged kidney. An example of it is the hemodialysis, the CRRT, and the PD. As for the indications for a renal replacement therapy, first is when the serum BUN and creatinine levels can be decreased, where the presence of uremic signs and symptoms are affecting all body systems, causing nausea and vomiting, severe anorexia, weakness, and mental confusion. For the second indication is the fluid excess is compromising the heart and the lungs, wherein fluid overload that is not responsive to diuretics and fluid restriction. And for the last indication, hyperkalemia and metabolic acidosis can't be treated successfully. So hyperkalemia that is causing fatal cardiac dysrhythmias and metabolic acidosis that can't be treated successfully. So, hemodialysis is a treatment to extract nitrogenous substances from the blood and to remove excess fluid through a dialyzer. This hemodialysis is the most common form of renal replacement therapy. Take note that this hemodialysis is not a cure for kidney failure, nor it does not compensate with the loss of endocrine or metabolic functions of the kidney. Hemodialysis is used for patients who are acutely ill and require short-term dialysis for days to weeks until kidney function resumes, and also for patients with advanced chronic kidney disease and end-stage kidney disease who require long-term or permanent renal replacement therapy. So, in hemodialysis, the unfiltered blood is diverted from the patient to a machine via the use of a blood pump to the dialyzer, where toxins are filtered from the blood and the blood is returned to the patient. This hemodialysis is done 3 to 4 times per week. This is what we call the intermittent hemodialysis, where most patients undergo through this, which involves treatments 3 times a week or within an average treatment duration of 3 to 5 hours in an outpatient setting. So moving on to where a patient can have a dialysis. For the dialysis center, where healthcare professionals set you up and hook you on a dialysis machine. So most people go to a dialysis center for treatment. At the dialysis center, healthcare professionals set up and help you connect to the dialysis machine. A team of healthcare workers will be available to help you. As for the home setting, for longer and frequent dialysis. So home hemodialysis lets you have longer or more frequent dialysis, which comes closer to replacing the work healthy kidneys do, usually 3 to 7 times per week. and with treatment sessions that last between 2 and 10 hours, and machines for home use are small enough to sit on an end table. Proceeding to the types of vascular access.
So one important step before starting hemodialysis treatment is having minor surgery to create a vascular access. So your vascular access will be your lifeline through which you'll connect to the dialyzer. First is the arteriovenous fistula or AVF. So a fistula or anastomosis, meaning communication, created surgically, usually in the forearm by joining or anastomosing an artery to a vein, either side to side or end to side. Next is the arteriovenous vein graft or AVG. So this AVG can be created by subcutaneously interposing a biologic, semi-biologic, or synthetic graft material between an artery and vein. The arteriovenous fistula is considered the best option because it provides highest blood flow for dialysis and is less likely to become infected or clot, and it also lasts longer. The AV graft is the next preferred choice for a permanent access. It is done in patients with compromised vascular systems like diabetes. They often require a graft because their native vessels may not be suitable for creation of an AVF. And AVG is usually placed in the arm but may also be placed in the thigh or chest wall. We also have the hemodialysis catheter. This is a soft tube that is placed in a large vein, usually in the neck. These catheters have two openings inside. One is a red, meaning arterial, opening to draw blood from your vein and out of your body into the dialysis pathway, and the other is a blue opening that allows clean blood to return to your body. So we can see the figure here that the double lumen cuffed hemodialysis catheter is used in acute hemodialysis.
And moving on to how the hemodialysis works. So, diffusion, osmosis, and ultrafiltration are the principles on which hemodialysis is based. And a pressure monitor and pump work together to keep the flow at the right rate. And then, blood enters at one end of the filter and is forced into many very thin hollow fibers. The toxins and waste in the blood are removed by diffusion, that is to dialysate. So dialysate solution enters the dialyzer. The dialysate is a solution that circulates through the dialyzer that helps remove the unwanted waste products from the blood. The electrolyte level in the patient's blood can be brought under control by properly adjusting the electrolytes in that dialysate solution. Used dialysate solution is pumped out of the machine and discarded. And then the blood goes through another pressure monitor and an air trap to make sure it's safe to go back into the body. So the clean blood returns to the body.
For the nursing responsibilities, the focus of nursing care for adults with CKD is to manage problems and reduce the effects of complications. Here are the nursing responsibilities. Interventions should include monitoring intake, output, and patient weight. Next, assessing patient's cardiopulmonary status, laboratory values, heart rate and rhythm, and also neurological status. Next, we have to maintain a position of comfort to facilitate adequate ventilation. And we also have to administer prescribed medications like diuretics, ACEIs, and ARBs to control blood pressure. Prior to starting each hemodialysis session, we have to assess the patient's fluid status. And during the hemodialysis, the blood pressure, vital signs, and electrolytes are watched carefully. We also have to remind the patient to watch what he eats or drinks in between treatments. And always remember that we have to maintain aseptic technique. And we also must provide psychosocial support and self-management education to the patient.
Next is the complications of hemodialysis. First is the elevated triglycerides. With the initiation of dialysis, disturbances of lipid metabolism or hypertriglyceridemia are accentuated and contribute to cardiovascular complications. Second is the heart failure, coronary artery disease, angina, stroke, and peripheral vascular insufficiency. Heart these diseases may occur and can incapacitate the patient. Also, cardiovascular disease remains the leading cause of death in patients receiving dialysis. Next is the Curling's ulcer. So, gastric ulcers may result from the physiologic stress of chronic illness, medication, and pre-existing medical conditions, which is the Curling's ulcer. And this is often referred to as stress ulcers because they are complications of severe stress on the body. Next is the sleep disturbances. Many people undergoing hemodialysis experience major sleep problems that further complicate their overall health status. Early morning or late afternoon dialysis may be a risk factor for developing sleep disturbances. As for the hypotension, this may occur during the treatment as fluid is removed. Nausea and vomiting, diaphoresis, tachycardia, and dizziness are common signs of hypotension. Next is the muscle cramps due to rapid shifts of electrolytes and fluids.
Other complications of dialysis treatment may include episodes of shortness of breath often occur as fluid accumulates between dialysis treatment. Next, exsanguination may occur if blood lines separate or dialysis needles become dislodged. Dysrhythmias may result from electrolyte and pH changes or from removal of antiarrhythmic medications during dialysis. Chest pains may also occur in patients with anemia or arteriosclerotic heart disease. And dialysis disequilibrium results from cerebral fluid shifts. Signs and symptoms include headache, nausea and vomiting, restlessness, decreased level of consciousness, and seizures. This dialysis disequilibrium is rare and more likely to occur in acute kidney illness or when BUN levels are very high.
Continuous renal replacement therapy. It is a method used to replace normal kidney function in patients who are hemodynamically unstable by circulating the patient's blood through a hemofilter and returning it to the patient. Continuous renal replacement therapies may be indicated for patients with acute or chronic kidney disease who are too clinically unstable for traditional hemodialysis, for patients with fluid overload secondary to oliguric kidney disease, and for patients whose kidney cannot handle their accurately high metabolic or nutritional needs. There are 6 medical products required to perform CRRT on a patient. First, blood purification machine. It is the machine that pumps the blood, controls the rate of blood flow, and includes software to safely monitor therapy delivery. Second, a dialysate. It is a fluid that carries toxin away from the filter. Third, replacement fluid. It is a specialized sterile fluid also used to flush toxins from the body but also to replace electrolytes, other blood elements, and volume lost during the filtration process. A filter is a machine component that removes fluid and uremic toxins. Anticoagulation method is a type of drug that helps the blood flow through the system, lessening the likelihood that the blood will clot in the filter. Last is a blood warmer. It efficiently maintains a patient's blood temperature during blood purification therapy. The nursing responsibilities include weighing the patient daily to assess fluid removal, Remember that anticoagulation during CRRT can lead to bleeding, so monitor for signs and symptoms of bleeding in the oral mucosa, gastric aspirate, stool, and injection sites. Check coagulation studies regularly. Take steps to prevent hypothermia. During CRRT, about 150 to 250 ml of blood volume remains outside of the body in the CRRT circuit. Therefore, blood may become cool and cause the patient's temperature to drop. Monitor temperature regularly. To prevent hypothermia, manufacturers provide warmers for CRRT solutions or blood warmers to warm the blood as it returns to the patient. Using a warming blanket also helps prevent hypothermia. Check blood urea nitrogen and creatinine levels at least daily to assess CRRT efficacy. Routinely monitor the patient's complete blood counts to check for unintended blood loss in case the CRRT circuit suddenly clots. Check electrolyte levels. Electrolytes are filtered out in the ultrafiltrate removed by the CRRT. Hypophosphatemia is common in patients on CRRT and can be treated with supplements or by adding phosphate to CRRT fluids.
Peritoneal dialysis is a way to remove waste products from your blood when your kidneys can't adequately do the job any longer. So it is another type of RRT and may be used for people who cannot tolerate hemodialysis or someone who chooses this method. So in peritoneal dialysis, the peritoneum is utilized as the filtering membrane. So how does peritoneal dialysis work? A soft plastic tube or decatheter is placed into your belly by surgery. A sterile cleansing fluid, also called dialysate, is put into your belly through this catheter. Waste and extra water seep across the lining of the belly into dialysate, which then washes back out, bringing the waste and extra water with it. After the filtering process is finished, the fluid leaves your body through the catheter. A dialysate usually made up of fluid with high dextrose or sorbitol solution. The dialysate is infused to the peritoneal cavity through an access device. Usually, dialysate volume is from 1000 ml to 3000 ml. It takes about 10 minutes for dialysate to infuse into the peritoneal cavity and remains there for prescribed amount of time, which as dwell time. The dialysate bag is then lowered and allowed to drain. The drainage is now called as the effluent. Exchange is the entire process of infusing and draining the dialysate. The effluent should be clear or straw-colored. Any signs of cloudiness may indicate an infection. Bloody streaks may indicate trauma or any other bleeding in the peritoneal cavity. This should alert the patient to call his physician. The dialysate should be infused in the body temperature. The cold dialysate causes vasoconstriction and may restrict the blood flow in the peritoneal cavity, affecting the effectiveness of the dialysis. For the approaches of peritoneal dialysis, we have here the continuous ambulatory peritoneal dialysis or CAPD and the automated PD or the continuous cyclic peritoneal dialysis. So the CAPD is peritoneal dialysis that can be done manually without a machine throughout the day. The patient fills his or her abdomen with dialysis solution and later drains the fluid. Gravity moves the fluid through the tube and into and out of the belly. Exchanges, often referred to as passes, can be done 3 to 5 times a day during waking hours. The patient must have the energy and the desire to be active in their treatment and also has the ability to learn and follow instructions, usually done 4 times a day every day. Patients with vertebral disease or arthritis cannot tolerate this approach as this causes pressures in the back. Also, patient with colostomy is a contraindication of this approach as this increases the risk for infection. So for the automated PD or the continuous cyclic PD, this requires the use of special dialysis machine that can be done at home. This type of dialysis is done automatically even while you are sleeping. The PD catheter is usually connected to a cycler machine usually at night and the exchange is done automatically while the patient is asleep. The patient usually receives 3 to 5 exchanges during the night. A fresh dialysate is infused to the abdomen in the morning and the catheter is disconnected from the cycler. The dialysate remains in the abdomen until the catheter is reattached to the cycler at night. So the patient has more freedom.
So these are the complications of peritoneal dialysis. First is exit site infection. It is the infection of the catheter site insertion. It was defined as purulent discharge with or without erythema of the skin at the catheter epidermal interface. Next one is peritonitis, the major complication of the peritoneal dialysis. It is an inflammation of the lining or peritoneum surrounding your abdominal organs. It is usually caused by bacteria that have entered your skin, PD catheter, or from inside your body to your bowel. Next is impaired body image. Infusion of fluids in the abdomen and devices like the catheter and bags attached. Next is depression. This may be due to unpredictability of the disease, the overwhelming responsibility of self-care, financial difficulties, and psychosocial and sexual impact of the disease and treatment. And lastly, sexual problems. Next is caring for the person with peritoneal dialysis. So, addressing psychosocial needs. Arrange meeting with persons with peritoneal dialysis who were able to adapt well. Open opportunity for patient to raise concerns regarding body image and sexuality. Referral to counselor and or sex therapists. Next is addressing self-care needs. So, assess the ability of the patient and his family to learn and perform peritoneal dialysis care. Teaching the patient and training him as well as his family members on peritoneal dialysis procedure and caring for the patient and the device in a comfortable and overwhelming approach. Then teach and encourage the patient to increase fiber and protein in the diet. Avoid high carbohydrate containing foods and no sodium, potassium, and fluid restrictions. And next is continuing care. Provide hotline of the hospital's outpatient and community health department. Referral to home health nurse, and for elderly clients with ESRD, suggest for transfer to a long-term skilled nursing facility may help. Then next is caring for the hospitalized patient on dialysis. So first is protecting the vascular access. Assess the vascular access for patency. Do not use the arm with the access for any procedure. Then observe for any signs of infection. Next is precaution on IV therapy. Regulate fluids strictly and infuse IV fluids using volumetric infusion pumps. Watch out for signs and symptoms of FVE and accurate INO. Then monitor symptoms of uremia and assess cardiac and pulmonary functions. So assess CV status by checking apical and peripheral pulses. Look for pulsus paradoxus or a decrease in blood pressure more than 10 millimeters of mercury during inspiration. Then listen for murmurs, pleuritic friction rub, or muffled or distant heart sounds. Look for any ECG changes and assess lung sounds and oxygen saturation as well as respiratory effort. Next is managing pain and discomfort. So, uremic pruritus may be managed through meticulous skincare. So, in meticulous skincare, application of emollients or moisturizers to reduce itching. Avoid applying anything near or at the vascular access site. Antihistamines are usually given in low doses. Next is controlling electrolyte levels and diet. Next is monitor blood pressure. Next is prevent infection. So in preventing infection, strict aseptic technique in caring and cleaning the vascular access. Next is cautious administration of medication. So check if the medications contain any potassium or magnesium. Check if the drug dosage is adjusted to compensate with the renal condition. And teach patient to avoid taking OTC drugs or herbal supplements without consulting the physician. And lastly, provide emotional support. So, referral of the patient and the family to support groups, referral to counselor or spiritual advisor, referral to mental health personnel, and referral to social services.
A kidney transplant is a surgical procedure to place a healthy kidney from a living or deceased donor into a person whose kidney no longer function properly. As we all know, kidney's main function is to filter and remove waste, minerals, and fluid from the blood by producing urine. That's why people with end-stage renal disease need to have waste removal from their bloodstream through a machine which is known as dialysis or a kidney transplant to stay alive. Only one donated kidney is needed to replace two failed kidneys. There are three types of kidney transplantation. First is the deceased donor kidney transplant. It is when a kidney from someone who has recently died is removed with consent of the family or from a donor card and placed in a recipient. Next one is the living donor kidney transplant. It is when a kidney from a living donor is removed and placed into a recipient. And the third one is the preemptive kidney transplant. It is when the client receives a kidney transplant before his or her kidney function deteriorates to the point of needing dialysis to replace the normal filtering function of the kidneys. Now let's proceed to the preoperative management. First, complete physical examination. This is to detect and treat any conditions that may cause complications. Second, tissue typing, blood typing, and antibody screening. Check the compatibility of the donor and recipient's tissue. Third, urinary exams. Assess bladder neck function and detect urethral reflux. Fourth, check for any presence of infection. Fifth, administration of immunosuppressant drugs. It is important to lower the body's ability to reject a transplanted organ. And 6. Psychosocial evaluation. The stress, financial issues, and support by family are assessed. This issue can greatly affect the outcome of the transplant. Now let's tackle about the preoperative nursing care. First, help the client to reduce anxiety by teaching about the procedure and post-operative course and care. Next, encourage the patient to express feelings and ask questions. Third, assess support system and ability to care for self after surgery and follow medical regimen. Fourth, explain to the client that the rejection of donated organ is the major obstacle in the transplantations. Reassure the client that rejection usually isn't life-threatening and the client can resume dialysis if needed. Fifth, begin administering immunosuppressant drugs. Discuss the purpose and the possible adverse effect with client. Monitor for increased BP and signs of anaphylaxis. 6. Plan for client to undergo dialysis the day before surgery, cleansing enema, and many laboratory tests. Kidney transplant surgery carries a risk of significant complications including blood clots and bleeding, leaking from or blockage of the tube which is the ureter that links the kidney to the bladder, infection, failure or rejection of the donated kidney, an infection or cancer that can be transmitted with the donated kidney, death, heart attack, and stroke. Now let's proceed to the kidney transplantation procedure. It is performed with general anesthesia, so the patient is not awake during the procedure. The surgical team monitor his or her heart rate, blood pressure, and blood oxygen level throughout the procedure. The surgeon makes an incision in the lower part of the one side of patient's abdomen and places the new kidney into the patient's body. His or her own kidneys are left in place unless they are causing complications such as high blood pressure, kidney stones, discomfort, or infection. The blood vessels of the new kidney are attached to the blood vessels in the lower part of the abdomen, just above one of the legs. The new kidney's ureter is connected to the bladder. Let's now discuss about the post-operative medical management. First is the administration of a combination of immunosuppressing drugs such as steroids, cyclosporine, tacrolimus, and methotrexate. Note that the doses of immunosuppressive drugs are gradually tapered off over a period of several weeks depending on the immunologic response. Next, assess for any signs of adverse effects of these drugs such as nephrotoxicity, cardiotoxicity, hepatotoxicity, or neurotoxicity, infections, and cancer. Third, assess the adequacy of immunosuppression. Watch out for any signs and symptoms of organ rejection. Fourth, assess the function of the newly transplanted kidney. Fifth, diminishing signs and symptoms of end-stage renal disease will be observed. Though kidney transplants are often successful, there are some cases when they are not. It is possible that the body may refuse to accept the donated kidney shortly after it is placed in the body. The immune system attacks the donated kidney because it recognizes it as a foreign tissue. There are 3 types of renal transplant rejection. Let's discuss first about the hyperacute renal transplant rejection. It occurs within hours of surgery. It results from antibody reactions to donor antigens. It occurs rarely now because of better histocompatibility assessment. Its manifestations include urine output stop. Examination of the transplanted kidney shows blue flaccid appearance. And its managements are: transplanted kidney must be removed, and the client must resume dialysis until another kidney is available. Next is the acute renal transplant rejection. It occurs within days to months after surgery. The body mounts an immune system defense against the tissue in donor organ. Its manifestations include urine output drops sharply, blood urea nitrogen and creatine rise, possible fever, graft tenderness, and swelling. The management for these are increased dosage of immunosuppressive drugs, may add or include steroids and monoclonal antibodies. Lastly, the chronic renal transplant rejection. It occurs from months to a year after surgery. The etiology is unclear but may involve immune response to donor organ. Its manifestations includes more gradual decline in kidney function, including urinary output and blood urea nitrogen and creatine. Proteinuria may occur. The managements are: there are no specific treatment. The client must resume hemodialysis caused by the loss of graft until or unless another donor kidney is transplanted. To help prevent the new kidney from being rejected, the doctor will give the client immunosuppressants, which are medicines that decrease the immune response so that the body is less likely to reject the new kidney. These medications can cause a variety of side effects including bone thinning or osteoporosis and bone damage or osteonecrosis, diabetes, excessive hair growth or hair loss, high blood pressure, and high cholesterol. Now let's tackle about the post-operative nursing care. First, perform baseline assessment such as vital signs, level of consciousness, and status of dressing. Second, encourage frequent position changes, coughing, and deep breathing, early ambulation if appropriate. Third, use special infection control measures such as strict aseptic technique when changing dressing or performing catheter care. Limit contact with staff and visitors. Wear surgical mask when entering the client's room. Monitor white blood cells count and notify the physician of significant drop or increase. Fourth, observe signs of tissue or organ rejection such as fever, tenderness, swelling of the surgical site, increase in white blood cells, decreased urinary output, and sudden weight gain. Fifth, provide analgesic medications. Sixth, monitor urinary output closely. Report urinary output of less than 100 ml per hour. A decrease in urine may indicate thrombus formation at the renal artery anastomosis site. Expect blood-thin urine for several days and may irrigate the catheter as ordered using strict aseptic technique. 7th, monitor daily renal function tests such as serum creatinine, 24-hour creatinine clearance, blood urea nitrogen, urine creatinine, urine pH, protein and specific gravity, and serum electrolytes. 8. Monitor cardiac function. 9. Weigh patient daily. Now let's proceed to the home care for the post-kidney transplant client. First, carefully measure the input and output. Notify the physician if the urinary output falls below 600 ml for any 24-hour period. Second, instruct patient how to collect 24 urine samples. Next, advise patient to weigh self at least twice a week. Fourth, drink at least 1 to 2 liters of fluid daily unless advised otherwise. Next, report signs of rejection such as redness, warmth, tenderness or swelling over the kidney, fever, decreased urinary output, and elevated BP. And 6. Avoid crowds and persons with unknown infection for 3 months after surgery. 7. Practice regular, moderate exercise but avoid heavy lifting or contact sports for at least 3 months. 8. Use shoulder but not lap-style seat belts. Next, wait at least 6 months before engaging in sexual activity. 10th, advise patients not to abruptly stop immunosuppressive therapy. And lastly, advise patients to avoid over-the-counter drugs or herbal supplements without consulting the physician first.